3 nights ago, something happened to you while you were sleeping. You do not know about it because you were unconscious when it occurred. Nobody was watching, no alarm went off, no pain woke you up. You rolled over at some point, maybe adjusted your pillow, maybe got up once to use the bathroom. And by morning, everything felt more or less normal. But inside your brain, during those quiet hours, a blood vessel briefly lost its ability to deliver adequate blood flow to a section of brain tissue. The interruption lasted somewhere between a few seconds and a few minutes. The affected area was small enough that no dramatic symptoms appeared. No facial drooping, no arm weakness, no slurred speech, none of the warning signs on the stroke awareness poster in your doctor's waiting room. What you may have noticed the next morning was something much more subtle. A headache that was a little different from your usual ones. A few seconds of confusion when you first woke up that you attributed to not sleeping well. A word that took slightly longer to find than it should have. A moment of dizziness when you stood up that passed quickly enough to dismiss. And then you moved on with your day. Because none of those things felt serious enough to call anyone about. What I just described is called a transient ischemic attack. Most people know it as a mini stroke. And the reason I am starting this conversation the way I did is that I want you to feel, before I give you a single piece of clinical information, how easily and how completely a mini stroke can happen without the person who experienced it ever knowing. My name is Dr. William Madison. I have been in clinical practice for more than 20 years, and the conversation I am about to have with you is one of the most important I know how to have. Not because mini strokes are rare, they are not. Not because the symptoms are impossible to recognize once you know what to look for, they are not. But because the window between a mini stroke and a full, devastating stroke is both shorter and more predictable than most people realize. And almost nobody is using that window the way they should. Here is the number that I want you to hold in your mind for the next several minutes. Approximately 1 in 3 people who have a mini stroke will go on to have a full stroke within the following year. And of those, half will have that full stroke within the first 48 hours after the mini stroke occurred. 48 hours. That is the window. And most people who experience a mini stroke during sleep never know the clock has started. I want to spend time today on 4 things. First, what a mini stroke actually is at a biological level, because the mechanism changes how you understand the symptoms. Second, the specific warning signs that appear during sleep or immediately upon waking that are being misattributed to normal aging millions of times every year. Third, the risk factors that significantly increase the likelihood of a nocturnal mini stroke and that can be identified and addressed before a full stroke occurs. And fourth, the specific actions to take if you recognize any of these signs in yourself or someone you love. Let us start with what is actually happening inside the brain during a mini stroke, because I think once you understand the biology, you will never again dismiss a subtle morning symptom quite as quickly. Your brain receives blood through a network of arteries. That blood carries oxygen and glucose, the 2 things brain cells cannot survive without even briefly. When blood flow to any region of the brain is interrupted, even partially, even temporarily, the brain cells in that region begin to experience stress within seconds. Their function degrades, their signaling becomes unreliable. If the interruption is brief enough, the cells recover when blood flow is restored. No permanent damage is detectable on standard imaging. The episode meets the clinical definition of a transient ischemic attack, rather than a full stroke. But here's what the word transient does not capture. The same process that produced the mini stroke, the narrowed artery, the small clot, the blood pressure instability, the vessel wall damage, is still present after the symptoms resolve. Nothing about the underlying condition has been corrected by the fact that the symptoms passed. In many cases, the mini stroke is the clearest possible biological signal that a full stroke is being set up, and that the conditions for it are already in place. Research published in a major neurology journal found that the stroke risk in the 2 days following a recognized mini stroke is between 15 and 20 times higher than baseline. That elevated risk is not hypothetical. It is the result of the same underlying vascular pathology continuing to generate the same threat, now with a vessel wall that has already been stressed by the initial event. The reason nocturnal mini strokes are particularly dangerous is not that they are more severe. It is that they occur during the one period of the day when you have no ability to observe your own symptoms. You cannot notice facial drooping in your sleep. You cannot assess your speech clarity or your arm strength while you are unconscious. By the time you wake up, the acute symptoms, if there were any, have often resolved. What remains are the subtle residual signs that almost everyone misreads. Let me walk you through those signs now. And I want to ask you to read this section carefully, because I am going to describe things that may have happened to you recently and that you may have explained away. The first sign is waking up with a headache that feels different from your usual headaches. Not necessarily more painful. Different. A location that is unusual for you. A quality that is unfamiliar. Perhaps a dull pressure at the back of the head rather than the tension across the forehead you normally experience. A headache that is present before you have done anything to provoke it, before you have been in any position that might cause neck tension, before you have had caffeine or missed caffeine. A headache that presents immediately upon waking, before you stand up, before the day has made any demand on you, is worth taking seriously. The brain does not normally produce pain signals that intense during the restful state of sleep without a reason. Vascular events, including the disrupted blood flow of a mini-stroke, are among the reasons. The second sign is a period of confusion or disorientation upon waking that lasts longer than the normal few seconds of coming out of deep sleep. Most people experience a brief moment of reorientation when they wake up. A second or two where you remember where you are, what day it is, what you were doing yesterday. That is normal and brief. What is not normal is confusion that persists for several minutes. Waking up and genuinely not knowing for a minute or more what time of day it is, what you are supposed to be doing, or feeling a strange disconnection from your surroundings that takes meaningful time to resolve. Many people who experience this describe it as waking up feeling drunk, or waking up feeling like their brain has not turned on yet. They attribute it to not sleeping well, to the medication they took before bed, to getting older. In some cases, those explanations are correct. But in others, the confusion is a residual neurological effect of reduced blood flow to a region of the brain during the night. The third sign is one-sided weakness or clumsiness that is present when you first wake up and that you may not notice until you try to do something specific. You reach for your phone and your hand feels slightly less coordinated than usual. You try to grip your toothbrush and notice your grip is weaker on one side. You stand up and one leg feels less reliable than the other for the first few steps. These sensations may last only a few minutes and then resolve as you move around and wake up fully. The critical phrase here is one-sided. General morning stiffness affects both sides relatively equally. A neurological event affects one side because the brain is organized such that each hemisphere controls the opposite side of the body. If the weakness, the clumsiness, or the uncoordinated feeling is distinctly more pronounced on one side than the other, that asymmetry is a neurological signal that should not be dismissed. The fourth sign is a visual disturbance that is present briefly upon waking and that passes within minutes. This might be a small area of blurred vision that was not there when you went to sleep. A brief episode where part of your visual field seemed darker than it should. A moment where you saw what might be described as a dark curtain across one eye, present briefly and then gone. Vision-related mini-stroke symptoms are particularly easy to dismiss because eyes are expected to take a few moments to adjust after sleep, and because the symptoms pass quickly. The visual cortex, which processes sight, sits at the back of the brain and is supplied by the posterior circulation. Mini-strokes affecting this region produce visual disturbances that are often brief and one-sided. If you notice something unusual about your vision when you first woke up, particularly if it was in one eye only or in one part of your visual field, and particularly if it resolved on its own within minutes, that history is worth discussing with your doctor specifically. The fifth sign is a speech disturbance that lasted briefly and then resolved. This might be waking up and finding that words were harder to produce than normal for the first few minutes of the day, reaching for a word and not finding it quickly, beginning a sentence and losing track of it midway, saying a word that was not quite the right word, close but not accurate, without fully realizing it in the moment. A partner or family member commenting that you seemed confused or were saying something that did not make sense right after waking up. Speech production is one of the most neurologically complex things the human brain does, and it is also one of the most reliable early indicators of vascular events affecting the language centers of the brain. Brief speech difficulties that resolve within minutes are a classic presentation of a transient ischemic attack and are very commonly attributed to not being fully awake yet. The sixth sign is unexplained nausea or dizziness immediately upon waking, particularly with any rotational quality. A genuine spinning sensation upon waking, where the room feels like it is moving, or you feel like you are moving when you are not, is called vertigo. While vertigo has many causes, including inner ear conditions, vertigo that appears for the first time or suddenly worsens overnight, particularly when combined with any of the other signs I have described, warrants urgent evaluation. Dizziness alone, the general lightheadedness of standing up too quickly, is not the same thing and has different causes. The distinction that matters is whether there is a true rotational quality, a sensation of spinning or movement, and whether it was present before you stood up, while you were still lying in bed. Now I want to talk about who is most at risk for nocturnal mini-strokes, because understanding your personal risk profile is what determines how urgently you should act on any of these signs if you recognize them. The first and most significant risk factor is uncontrolled or inadequately controlled blood pressure, particularly in adults over 65. High blood pressure is the single most powerful driver of stroke risk. During sleep, blood pressure normally follows a pattern called dipping, where it drops by 10 to 20% compared to waking levels. This nightly dip appears to be protective for the brain and heart. In a significant proportion of older adults with hypertension, this normal dipping pattern is absent. Their blood pressure remains elevated through the night, continuously stressing blood vessel walls during the hours when the brain should be in its most protected state. Research has found that adults whose blood pressure does not dip normally during sleep have substantially higher stroke risk than those whose blood pressure does dip, even when their daytime blood pressure readings are similar. This is a pattern that a standard office blood pressure measurement cannot detect. It requires either a 24-hour ambulatory blood pressure monitor that you wear throughout the day and night, or consistent home monitoring at consistent times, including first thing in the morning, before you have gotten up and moved around. If you have been told your blood pressure is controlled based on office readings, but you have not been evaluated for the nocturnal dipping pattern, that is a specific question worth raising with your doctor. The second major risk factor is atrial fibrillation, including paroxysmal atrial fibrillation that occurs intermittently and is not always captured on a standard electrocardiogram. Atrial fibrillation is an irregular heart rhythm in which the upper chambers of the heart beat chaotically, rather than with coordinated regularity. This chaotic beating allows blood to pool in a small structure of the heart called the left atrial appendage, where it can form clots. Those clots can travel to the brain and cause strokes or mini-strokes. Paroxysmal atrial fibrillation, meaning atrial fibrillation that comes and goes rather than being continuously present, is particularly likely to be missed on a standard ECG taken during a routine appointment, because the rhythm may be normal at the time of testing. Sleep is a common trigger for atrial fibrillation episodes, partly because of the autonomic nervous system changes that accompany the sleep-wake transition. If you have ever been told you have an irregular heartbeat, or if you have ever felt palpitations, a racing or fluttering sensation in your chest, particularly at night or upon waking, atrial fibrillation evaluation is a conversation to have with your doctor, specifically in the context of stroke risk. The third major risk factor is sleep apnea, which is present in a substantial proportion of adults over 65 and is dramatically underdiagnosed in this age group. Sleep apnea causes repeated episodes during the night where breathing partially or completely stops for 10 seconds or more. Each of these episodes produces a brief but significant drop in blood oxygen. It also causes a spike in blood pressure as the body's stress response activates to restart breathing, and it disrupts the normal nocturnal dipping pattern in blood pressure that protects the brain during sleep. The combination of repeated oxygen drops, repeated blood pressure spikes, and absent nocturnal dipping creates a biological environment during sleep that significantly elevates the risk of vascular events, including mini-strokes. Research has found that adults with untreated severe sleep apnea have a stroke risk approximately 3 times higher than those without it. The classic symptoms most people associate with sleep apnea are loud snoring and daytime sleepiness. But many older adults with significant sleep apnea do not snore loudly, or live alone and have no partner to observe their breathing. Waking with headaches, waking feeling unrefreshed despite adequate hours in bed, needing to urinate multiple times per night, and waking with a dry mouth or sore throat are all potential indicators that are worth discussing with your doctor in the context of sleep apnea evaluation. The fourth major risk factor is the combination of diabetes or prediabetes with cardiovascular risk factors. Chronically elevated blood sugar damages the endothelial lining of blood vessels over time, making them more vulnerable to the kind of plaque buildup and vessel wall injury that produces the conditions for a mini-stroke. Adults with poorly controlled type 2 diabetes have approximately double the stroke risk of those without diabetes. And because blood sugar naturally rises during the overnight fasting period through a process called the dawn phenomenon, the nocturnal hours are a period of particular vascular stress for people with blood sugar management issues. The fifth major risk factor is being on multiple medications without regular review of their combined cardiovascular effects. Several common medication combinations can produce blood pressure drops during sleep that are more profound than intended, creating the kind of circulation instability that contributes to nocturnal vascular events. Diuretics taken in the evening, certain blood pressure medications that have peak effects during the night, and sedating medications that reduce blood pressure as a secondary effect are all worth reviewing specifically in the context of nighttime blood pressure stability. As we discussed in previous conversations, certain anticholinergic medications also affect cardiovascular regulation in ways that can contribute to nocturnal blood pressure instability. If you are taking 4 or more medications and have not had a comprehensive review specifically looking at their combined effect on blood pressure during sleep, that review is worth requesting. Now let me tell you what to do with this information, because information without a clear action path is just anxiety, and that is not what I am trying to create. If you recognize any of the morning symptoms I described, whether in your own recent history or in the history of someone you care about, the appropriate response is urgent evaluation. Not tomorrow, not at the next scheduled appointment, today. In the United States, a transient ischemic attack is treated as a medical emergency, equivalent to a full stroke in progress. The reason is that 48-hour window I described at the beginning. The evaluation that needs to happen includes brain imaging to identify whether any area of the brain shows evidence of infarction, a cardiac evaluation including a prolonged heart rhythm monitor to screen for atrial fibrillation, blood work including clotting studies and inflammatory markers, and a blood pressure evaluation that captures the nocturnal pattern rather than just a single office reading. If you go to an emergency department and describe the symptoms I have outlined, including the fact that they resolved on their own, you should be taken seriously. If you feel that you are not being taken seriously, specifically ask for a neurology consultation, and specifically ask about the TIA protocol, using those words. Medical teams respond differently when patients demonstrate knowledge of the appropriate clinical pathway. If your symptoms have resolved and you are no longer in the acute window, but you want to understand your personal risk level, schedule an appointment with your primary care doctor and ask specifically for a stroke risk assessment. Ask for a 24-hour ambulatory blood pressure monitor to evaluate your nocturnal dipping pattern. Ask whether a cardiac monitor to screen for paroxysmal atrial fibrillation is appropriate. Ask whether you should be evaluated for sleep apnea. Ask for your homocysteine level to be checked, as elevated homocysteine is a modifiable risk factor for stroke that is rarely included in standard blood panels but is straightforward to address with B vitamin supplementation when elevated. These are not aggressive or unusual requests. They are exactly the evaluation that current stroke prevention guidelines recommend for anyone with risk factors or concerning symptoms. The barrier is usually that nobody asks for them specifically, because nobody has explained why they matter. Let me close with something that I want you to remember long after the specific clinical details have faded. The brain is extraordinary at compensating for small injuries. A mini stroke that affects a small area can leave no permanent symptoms, precisely because the surrounding brain tissue compensates. That compensation is genuinely protective. But it also creates the dangerous illusion that nothing serious happened. Something serious happened. The blood vessel that narrowed, the clot that formed and dissolved, the blood pressure that spiked during sleep, the heart that beat irregularly for an hour. These events leave evidence in the vessel walls even when they leave no evidence in your symptoms. And that evidence is the setup for what comes next. The people who avoid full strokes after a mini stroke are almost always the people who treated the mini stroke as the warning it was, rather than the near miss they wished it had been. They went to their doctor. They had the evaluation. They found out which risk factor was driving the event, and they addressed it. That process cannot happen if you do not know the clock has started. Now you know. If someone in your life has mentioned any of the morning symptoms I described, a strange headache upon waking, confusion that took a few minutes to clear, a hand that felt clumsy for a moment, vision that was briefly off, please share this with them directly. Not as a general share to a group, but as a specific message to that specific person, because you thought of them while reading this, and you want them to have this information before they need it urgently. The window between a warning and a catastrophe is real. Use it. I'm Dr. William Madison. Take care of your brain. It is the most irreplaceable thing you have. Take care of yourself, take care of the people around you, and I will see you in the next video.